Eastern Time. Now, today's topic is Know Your Myeloma Therapy. We're going to be talking about Revlimid with Dr. Craig Cole. Now, I chose this topic because I want you to be educated about Revlimid and how the therapy works to treat myeloma. Now, for many of us, this drug is going to be something that we're going to be on for an extended period of time, and we need to understand how it works in our bodies. So it's now my pleasure to introduce to you our featured speaker, Dr. Cole. Dr. Cole is a board-certified hematologist who completed his undergraduate degree at Michigan State University and his doctoral degree at the Ohio State University College of Medicine. He began his postdoctoral training in internal medicine and hematology oncology at the University of Michigan Health System. He's had the opportunity to do post-follow-up laboratory research in the Jerome Leiper Multiple Myeloma Center of Medicine at Dana-Farber Cancer Institute, Harvard Medical School in Boston, Massachusetts. This opportunity led to a staff lectureship at the University of Michigan, concentrating primarily on clinical research in multiple myeloma. Dr. Cole then became an attending hematologist at Gunderson Health System in La Crosse, Wisconsin for 9 years. While in Wisconsin, he expanded his research interests to include multiple myeloma, non-Hodgkin's lymphoma, therapeutic apheresis, and myelodysplasia, participating as the on-site primary investigator for over 21 clinical trials. He then returned to the University of Michigan Rogel Center in Ann Arbor as an assistant professor in the Division of Hematology Oncology, with his primary clinical research in multiple myeloma. In May of 2019, he returned to Michigan State University College of Human Medicine at Breslin Cancer Center as the Director of Clinical Research in Hematology, Oncology, and Multiple Myeloma. He has published and presented his research at the ASH meetings and the Society of Apheresis national meetings. He also has a commitment to patient empowerment and education, working with several local and national patient advocacy associations. Dr. Cole, the time is now yours.
Well, thank you. Thanks for the kind introduction. And let me see, do you see my slide screen or do you see me?
Just you. We don't see your slides yet.
Okay, so let me change that to this. So now do you see my slide screen?
Yeah. Mm-hmm.
Perfect. So thanks for the introduction, Valerie. And I am pleased, so happy to be here to discuss Revlimid. And I was really excited about doing this talk because I was really fortunate enough to have been really in the mix of the history of Revlimid. I remember when there was a day before Revlimid, and sometimes people ask, why when I was in Wisconsin was I doing lymphoma and myelodysplastic research? Is because there was not much happening in myeloma until Revlimid, and I'll show you kind of that kind of story in just a little bit. So what we're going to discuss today is how, just like I mentioned, everything changed in the 2000s, in large part because of thalidomide and then Revlimid coming to in clinical trials and then to fruition. We'll talk about thalidomide, the grandfather of Revlimid, and the angiogenesis story. Then a little bit of myeloma biology to really show how that applies to the action of the immunomodulatory drugs in myeloma. We'll talk a little bit about the clinical trial data that supports the use of Revlimid, talk about the side effects and management, and then some conclusions. And so, back in the days when I had hair, when I had a high top fade, myeloma was a very different disease, a very different survival. In this curve, you can see the lines towards the bottom, and the dotted line is what the 5-year point was. And you see that the 5-year survival for myeloma in the 60s, 70s, 80s, and 90s was actually very much different than it was after 2000. And so suddenly, the survival of this disease went from being measured in the order of 3 to 4 years to suddenly significantly changing. And the red line is kind of where is probably even an underestimate of where we are today. So what happened to cause this change around 1999 and 2000? Well, prior to 1999, everything we were using was chemotherapy, high-dose chemotherapy for transplant, melphalan, vincristine, adriamycin, dexamethasone. And I did this when I was early in my training. We would use this high-dose dexamethasone to treat newly diagnosed myeloma. And the survival was very different. And then the paradigm shift happened where all of a sudden we started using these newer scientific drugs, and then the survival significantly changed, and we've never looked back from that. And it all began with thalidomide. And so what is thalidomide? And I think everyone kind of knows the story of thalidomide, that it was a drug that was developed after World War II in West Germany. And primarily it was used as a addictive a way to treat what was later known as post-traumatic stress syndrome from the people who fought in World War II. So it was initially advertised as a sedative hypnotic, and the drug company that tested it in mice and found that mice thalidomide was incredibly well tolerated. So well tolerated that around the world it was available without a prescription and was basically a cure-all for difficulty sleeping, different anxiolytic or anxiety disorders. And it was actually given to pregnant women because it helped with nausea and hyperemesis gravidum when women were early in their pregnancy. It was then, and a lot of the toxicity, especially the birth defects that were found with the drug, were kind of covered by the company. And when it went up for FDA approval in the United States, Dr. Frances Kelsey, who won the Congressional Medal of Honor, stood her ground and said, this, despite what the drug company is saying, this drug causes birth defects. And her efforts and her standing ground not only took the drug off the market, but it changed the FDA for forever. And the review process was completely overhauled to being very, very inclusive to make sure that the drugs are safe when they're released in the United States. But to her credit, the thalidomide was then put away in 1961 to not be seen again, and the idea was that it caused the birth defects that it caused was from an inhibition of blood vessel formation. Right when it was withdrawn from the market, Dr. Olson wrote a paper, and he gave, it was kind of a cure-all, and they gave the thalidomide to patients with advanced cancer. And he wrote a paper on this that showed that some patients that had advanced cancer, that using thalidomide actually slowed down their cancer. And actually patients had, at the end of their lives with these cancers, they were actually having an improvement in how they felt. And the two top cancers that showed benefit were kidney cancer and multiple myeloma. And those two cancers are actually highly angiogenic. And that was kind of a note that was left, that thalidomide worked for these two diseases, but of course it was then put away. So then fast forward to 1999, and 1999 and 1998, people were incredibly excited about angiogenesis, that cancer required blood vessels in order to sustain and grow, and that tumors produce lots of angiogenic growth factors that make blood vessels in order for the cancer to be fed. And one of the chief angiogenic growth factors was vascular endothelial growth factor, or VEGF. And at the same time, about 1999, there was a paper that changed my life, and the direction of my career changed when I read this paper by Angelo Vecca that talked about 67 patients that had myeloma, and it showed a connection between blood vessel growth and myeloma growth. This wasn't anything new. Dr. J.H. Wright, back in 1900, showed that myeloma was a highly angiogenic, had lots of blood vessels in those bone marrow biopsies that were done, in the very first bone marrow biopsies that were done. Very, very lots of blood vessels seen at that time. Angelo Vecca, then using new technology, showed, yes, that the panel A, where someone had active myeloma in 1999, lots of blood vessels seen, lots of those brown squiggly lines are blood vessels, and patients that had plateau phase or quiescent myeloma had less blood vessels. So the idea, of course, is that if you could slow down blood vessel formation, maybe you could slow down the disease. And in 1997, this idea of angiogenesis in cancer really came to myeloma. And what happened is that in this story, there are different versions. It's now basically legend of what occurred. But Dr. Bartologhi, which gave us maintenance therapy, who gave us a high-dose chemotherapy and transplant in myeloma, really one of the most famous myeloma doctors in history. Dr. Bartologhi had a patient who had several transplants, was on chemotherapy. His patient was doing very poorly, and the patient's wife went to Dr. Bartologhi and said, my husband is not doing well with his myeloma. I've heard about these angiogenesis agents. Could you find an anti-angiogenesis agent for my husband? So Dr. Bartologhi then takes up the challenge and calls Judah Folkman. Judah Folkman is a Nobel Prize laureate, is a pediatric surgeon, but he was doing research in anti-angiogenesis agents, predominantly for childhood diabetic retinopathy or childhood diabetic eye disease, because in diabetic retinopathy or diabetic eye disease, it's an overgrowth of blood vessels that cause blindness due to diabetes in these children. So he was using anti-angiogenesis agents to try and decrease the amount of blood vessels in children's eyes so they wouldn't go blind with diabetes. So Dr. Bartologhi in Little Rock, Arkansas, a myeloma doctor, calls Judah Folkman at Harvard and says, can I have an angiogenesis agent for my patient here with myeloma? And Judah Folkman gives him the one drug that would be least likely that you'd ever give a child with that as an anti-angiogenesis agent. He gives Dr. Bartologhi thalidomide. Dr. Bartologhi takes that thalidomide and gives it to his patient that had multiple rounds of chemotherapy, and it helped them, which then led Dr. Bartologhi to do a clinical trial and 37% reduction in myeloma protein, which was this pill was outperforming chemotherapy in the early 90s, with a follow-up at 3.5 years, and patients were still alive that had relapsed refractory myeloma refractory to chemotherapy. It really was. And this is when I first came into myeloma. And this was an incredible result of how this drug worked, that a patient's wife went to the doctor and asked for a treatment. And that doctor then goes out, seeks out that treatment, builds a clinical trial, and changes the world, changes myeloma. And a new class of immunomodulatory drugs was then discovered. So thalidomide was the first in class, but did have quite a few side effects, particularly neuropathy and sedation. So then lenalidomide, which is a derivative that was less toxic, was then developed and released in 2006, and was more, and not only did they decrease the side effects, but made it more potent. And a phase 2 trial showed how that it worked better than any other agent at that time for newly diagnosed myeloma. We'll talk about that in a bit. Subsequently, pomalidomide was then released, which was even more potent. And iberdomide is currently in late phase clinical trials for the use in myeloma. And the whole area of the immunomodulatory drugs and now the cereblon inhibitor drugs are really a incredible fountain of new drugs for myeloma built on the backbone of what thalidomide is. So how do these drugs work? How does thalidomide and Revlimid and the other drugs actually work? Well, that'll take a little for us to talk a little bit about myeloma biology. So here's a myeloma cell, and there's the interleukin-6 receptor on myeloma cells. And myeloma cells are very dependent upon interleukin-6. And there was a great effort to see how can we understand how myeloma cells grow. When IL-6 engages its receptor, it activates a number of pathways inside the myeloma cell. One is the JAK-STAT pathway, which activates BCL2 and MCL1, which tells the cells not to die. That's a bit, cells are supposed to die. But if they're told not to die, if they have anti-apoptosis, then they're immortalized. They won't die. It also activates the Revlimid kinase pathway, which tells the cycles to reproduce faster and increase cell proliferation. And then it activates the PI3 kinase pathway, which turns on NF-kappa B. And nuclear factor kappa B is the source of more supportive cytokines. So the cycle keeps on going. This leaves the myeloma cell immortal against chemotherapy and resistant against steroids, which is why from the 1960s up until the 1990s, these drugs were not very effective for multiple myeloma. And if IL-6 is so important, where does it get it from? It gets it from the bone marrow stromal cells, which is why myeloma is confined primarily to the bone marrow compartment, is because it gets the IL-6 it needs to grow and proliferate from the bone marrow stromal cells. So once a myeloma cell finds a bone marrow stromal cell, it releases a little bit of vascular endothelial growth factor to then find out, is this bone marrow stromal cell going to cooperate in my growth and proliferation? The bone marrow stromal cell then turns on its own NF-kappa B, which then produces IL-6, which is a signal to say that this bone marrow stromal cell is going to work to help proliferate the myeloma. So the myeloma cell then produces lots of IL-6, which pulls in more myeloma cells into this microenvironment that is conducive for myeloma growth. It then produces more VEGF to pull in blood vessels to feed the more myeloma cells in the microenvironment, and produces other supportive cytokines, which then causes the circuit to go around again, producing more IL-6 and more supportive cytokines, which then pulls in more myeloma cells. And remember how IL-6 kept the cells proliferating, not dying, and resistant to chemotherapy and to steroids, which then makes the myeloma cells immortal. And that circuit between the bone marrow stromal cell and myeloma cell is why myeloma cells proliferate. They then run out of room in the bone marrow and then go to the long bones and to the skeletal bones, and they attach to osteoclasts, the cells that wear bone down. And they hijack the osteoclasts to produce IL-6. So they leave the bone marrow to find other cells to feed them. And in turn, they try to produce more osteoclasts to give more room for myeloma cells by using rank ligand and decrease osteoprotegrin to increase osteoclast activity, which causes the bone destruction in myeloma. And they get rid of those osteoblasts by using cytokines such as DKK1 and RUNX2. You get rid of the osteoblasts and use the osteoclasts, which is why we have lytic lesions in myeloma, because the myeloma cells are looking for that IL-6 in order for growth, proliferation, and so they don't die. So how do these drugs work against myeloma? Knowing how the myeloma cells are so dependent upon the microenvironment, well, they use science. This is how these drugs work. So the first way that we look at it, how do the IMiDs, thalidomide and Revlimid work? Well, again, they use science. They inhibit DNA synthesis in myeloma cells to a very small degree, not much. It works a tiny bit like chemotherapy would. It doesn't really decrease blood vessel synthesis so much, but what it does do is it gets rid of that VEGF. So remember, VEGF is how those myeloma cells initially talk to those bone marrow stromal cells. Without VEGF, yes, blood vessel synthesis decreases, but they don't know where those bone marrow stromal cells are. They inhibit the adhesion of myeloma cells to bone marrow stromal cells. Remember, they're dependent upon it. If a myeloma cell isn't attached to a bone marrow stromal cell in osteoclast, they'll die in just a few days. And so inhibiting that adhesion has the myeloma cells die. They don't have those supportive cytokines. Again, these drugs get rid of IL-6. That is what we've been looking for myeloma for decades, is how can we get rid of IL-6 from its source? And the IMiDs, Revlimid and pomalidomide and thalidomide decrease IL-6. Without IL-6, the cells can't proliferate, they can't produce more cytokines, and they apoptose, they die away. And after years, we found out that one incredible thing that these drugs do is they activate the patient's own immune system. They activate the T cells to go after the myeloma cells and destroy it. And that was revolutionary. There wasn't hardly any drugs that did that. And so these were really an incredible breakthrough. And I remember being so excited when this was discovered. So again, there's cytotoxic effects due to multiple mechanisms of how the IMiDs work. They increase the pro-apoptotic factors, which cause the cell to die, and decrease those factors that helps keep the myeloma cells alive. They inhibit that NF-kappa B pathway, which is how you get all those supportive cytokines, and disturb the PI3 kinase pathway, so the cells have a difficult time proliferating. They increase, they have an effect in decreasing bone destruction by decreasing the supportive cytokines, especially rank ligand. So now they can't talk to those osteoclasts and receive cytokines from them. And of course, we talked about how they activate the immune system against the myeloma cells by decreasing tumor necrosis factor, IL-6 and IL-12, and increasing IL-2 and interferon, which gets those T cells to kill off the myeloma cells. So it really is a Swiss Army knife that this pill that a patient's wife told Dr. Bartolovi about had so much activity against this disease. It was really incredible. So then the hunt went on. How exactly does the Swiss Army knife work? And an article came out in Science that figured it out. It was cereblon. Cereblon is a chemical that is inside cells, and that's what the IMiDs, thalidomide, Revlimid, pomalidomide bind. By binding to the cereblon, which usually has lots of other different functions, binding to cereblon then causes Ikaros and Alos to then get degraded by the cell. They get ubiquitinated and get targeted for destruction. And downregulation of Ikaros and Alos, which is seen in this cartoon as IKZ, F1, and 3, get rid of those and downregulates IFR1 and MYC, which then causes the cells to die, and increases those other effects, such as IL-2, which activates T cells to go after the myeloma cells. And this is the incredible thing, that thalidomide fits right into that cereblon receptor, Lenalidomide and pomalidomide even fit into that cereblon receptor even better than thalidomide. And by binding into that cereblon receptor, it gets Ikaros and Alos to then be destroyed, and which then causes all those incredible effects. The incredible thing is that it wasn't like Revlimid was, or thalidomide was designed for this purpose. It wasn't like it was purposely made. It just happens that a patient's wife told Dr. Bartologhi to get a drug for her husband, which then led to, it just happens. If it had been a lung cancer patient, it wouldn't have worked. If it had been colon cancer, we had never heard of it. But it just happens that this drug just happens to work for this disease, and it changed everything. I think that was truly, truly a miracle that that key happened to fit into that lock, and saved so many lives. And so again, thalidomide has some activity, more angiogenesis than T cell regulation and NK cell activation. But look at lenalidomide and pomalidomide, much more powerful at turning on those T cells, turning on the immune system to destroy the myeloma cells, to have those anti-inflammatory properties and direct tumor effects. And that is really, I think, an incredible story. Revlimid was then tried in the mid 2000s for relapsed myeloma. I clearly remember having enrolling patients on the lenalidomide dex trial for relapsed refractory myeloma, and having patients fly from all over the country to enroll in this trial back in the early 2000s. And it had these incredible results that outpaced chemotherapy at that time. And then what really, really changed my life is I was working in the lab at Dana-Farber, and I got on and I had a late night in the lab, and I got on the elevator at about, like 10 o'clock at night. And I got on the elevator with Dr. Ken Anderson, who's the director of the Dana-Farber myeloma group there. And he said, "Craig, I got a secret to tell you." He said, "There's this new drug, thalidomide. Lenalidomide. We gave it to newly diagnosed myeloma patients, and the overall response rate was 91%. Prior to that, I was writing for melphalan and prednisone for my myeloma patients, and the overall response rate was 30%. So when he told me that this new drug, I got on the elevator just trying to go home. He gets on the elevator and tells me this drug works 91% of the time. I knew that the entire world for this disease was completely different. That changed my life. And that's why I stay in doing this. And I still am so excited to see how many things have happened. I can't wait to show you some of the data that's coming up, but only one patient didn't respond. And I remember giving melphalan and prednisone to patients and having half the patients responding at best. So this was really a revolutionary breakthrough. Then the SWOG S777 trial came out of RevDex versus Revlimid Velcade Index, and that the three drug RVD outpaced RD for progression-free survival and overall survival, which is now our standard of care for newly diagnosed patients, is RVD. And then Emory, I love the Emory RVD 1000 study because it gives us an insight of what the performance of RVD is. And the overall response rate, 97% after induction therapy and 98% after stem cell transplant. Progression-free survival with that first 65 months as compared to like 4 months with melphalan and prednisone. My goodness, it's incredible. I've been doing this for like 20 years. This is incredible. And the median overall survival of high-risk patients was 78, but for standard patients, it hasn't been reached yet. And if you were to ask me in 1999 and 2000 if this would have been possible, I would say no. And then they said, well, if it works, well, why don't we have patients restart and stay on Revlimid after transplant? and data from 4 large randomized trials where patients are either given Revlimid maintenance, no maintenance at all, over 2,000 patients. It showed that Revlimid maintenance post-transplant was associated with significant improvement in overall and progression-free survival and an improvement in overall survival. And we still don't quite know how long patients should be on Revlimid maintenance. But here are all the trials to the left that looked at Revlimid maintenance versus no maintenance. And all those trials showed that there were improvements in overall survival and progression-free survival, which led to the FDA approval of Revlimid for maintenance therapy for myeloma. A couple of years ago, the Stamina trial looked at how long people should stay on Revlimid maintenance. And they had patients elect to either, after transplant, either stop Revlimid maintenance after 3 years or continue on. And by stopping Revlimid at 3 years, patients started to relapse. And continued Revlimid patients didn't relapse at the same rate. And so that told us that we still don't know how long people need to stay on Revlimid maintenance, but staying on Revlimid maintenance beyond 3 years still remains a good idea. The thing that, to come to complete, to fruition of when we found out that that Revlimid was so good for newly diagnosed patients to today, the Griffin trial that I'm sure everyone has heard about, of the addition of daratumumab, the antibody against myeloma, plus RVD versus RVD alone for newly diagnosed patients. And in this study, transplant eligible patients were either given Dara-RVD or RVD, which is, of course, the current standard of care, followed by stem cell transplant, consolidation with RVD, and then maintenance with either Revlimid or Dara-Revlimid for approximately 2 years. And what I think is incredible is how well the overall responses at the end of consolidation, 99% overall responses for Dara-RVD and 91% for RVD, which is which is incredible, still incredible, but a little bit more with the addition of daratumumab. And the important part is deeper responses by the addition of daratumumab. And in transplant eligible patients, there were more patients that had a stringent complete response by addition of daratumumab to RVD at 51% versus 42%. And again, those responses deepened over time with more and more patients becoming MRD negative, especially during the maintenance phase. But we still need some more data on progression-free survival, although in talking to my myeloma colleagues, really Dara-RVD is becoming a standard. In fact, this is from the latest ASH meeting. You can see that in those curves for progression-free survival, that the curve for Dara-RVD is absolutely flat, which means patients aren't relapsing haven't had any further relapses at 36 months, while the RVD patients still 81% at 36 months is very good, but just a little bit better with Dara-RVD. So when you look at the regimens for myeloma over the years, when I first started when I was in training, and the very early days of my career, when we were using melphalan and prednisone, or vincristine, adriamycin, and dexamethasone chemotherapy, the best that we could get was about a 63% response rate. And really, I had never written down the term VGPR for a myeloma patient in the early 90s, because I never saw it happen. I'll be honest, I never back in the early 90s wrote down complete response, because I never saw it happen. All the responses were very short and never a deep response. Then you look at what happened when we introduced thalidomide and bertuzumab, Velcade, and lenalidomide. The responses went up dramatically. And then we started combining the old with the new, melphalan, prednisone, thalidomide, and the IMiDs plus the old drugs. Response rates and the depth of response started going up. So now you get to our current standards, with Revlimid being kind of the center point of those regimens. You're looking at 100%, 98% response rate. The deep response is well over 50%. And then the 4-drug regimens that I mentioned, where we have responses that are 99 and 100%, and the deep response is much, much higher. And so in just a few years, in just 20 years, we went from having 35% response rate to 100%, 99 and 100% response rate because of one drug. And I can't underemphasize, because a patient's wife talked to their doctor about a clinical trial. So let's talk about side effects. And I swear that I see all these commercials on TV. This is exactly what I think. I mean, everyone in the commercials seemed very happy, and everyone's like, "Oh." So what about the side effects of Revlimid and the IMiDs? Well, there are, in the first trial, which was a trial that was done in the I think it was 2010. Which was between melphalan, prednisone, and thalidomide versus Revlimid, dexamethasone. We saw that there are cytopenias associated with Revlimid, and specifically for the absolute neutrophil count being under 1,000, which is officially neutropenic. Happened about 26% of patients on the lenalidomide or Revlimid dex arm, and was a little bit higher when patients were on continuous Revlimid dexamethasone. I think we see that. We see not that the immune system is too compromised with the use of Revlimid, but it does decrease the neutrophil count a little bit, and thrombocytopenia. And I do tell my patients that their platelet count can go down over time with the use of Revlimid. At the initial start of therapy, that the counts, of course, are compromised because myeloma is in the bone marrow and is causing problems, but we usually see the counts improve as we get rid of the myeloma, and then Revlimid itself can cause a bit of thrombocytopenia, but usually not to the point of needing transfusions. And of course, there are a number of non-hematologic or non-blood related side effects, infections. And I think that especially in that first month of the diagnosis of myeloma, when the myeloma is very active and decreasing the immune system, the immunosuppressive effects of Revlimid, that combination does take a toll. So infections are not infrequent with multiple myeloma and at the onset with Revlimid. Fatigue, I've heard, I would say that even though these numbers are from the clinical trial, I would say the fatigue number is a bit higher than 9%. Cardiac disorders, especially heart rhythm problems, are not uncommon with Revlimid. And then we'll talk about venous thromboembolism or blood clots in a bit. There is a risk of secondary cancers that we discuss with our patients. In fact, in the early days of Revlimid, there was a brief hold that was put on the clinical trials with Revlimid because they saw that some patients were having secondary cancers. However, in close analysis, it was in those randomized trials where patients were either getting Revlimid or they were being followed and not receiving Revlimid, those clinical trials that prove how well maintenance therapy worked, that the advantage of control of the myeloma gave a much, much higher survival advantage than not using Revlimid maintenance. The risk of dying from a secondary cancer is less than 1%. And the cumulative index of having any cancer is less than 1% at 1 year and climbs very slowly. A lot of those cancers are skin cancers, like basal cell carcinomas, and skin squamous cell carcinomas. But more importantly, patients are living longer with this disease than they ever have. And so we do have to be very cognizant of the fact that patients can develop cancer with Revlimid. But the important thing is more important to not have the myeloma be the cause of death and very carefully observe patients when they're on Revlimid. Make sure we do skin exams, make sure that patients get their standard cancer screening for prostate, breast cancer, lung cancer, if applicable, and watch very carefully for that. But again, most of the cancers are fairly quote unquote benign cancers, such as skin cancers that can be remedied by a local resection. Some of the long-term effects of Revlimid that actually didn't come to fruition until we had patients on maintenance was the chronic diarrhea part, which is really important to talk about. And when we were first using Revlimid, we had patients have diarrhea and we didn't understand it. And unfortunately, a lot of patients didn't tell us that they were having diarrhea because they didn't want to stop the Revlimid. We now know that with long-term Revlimid use, can result in a very specific form of diarrhea called bile salt malabsorption syndrome. And what happens is that the Revlimid causes a slight damage to the lining of the intestine, where there's an accumulation of bile salts. Bile salts are kind of the soap that dissolves fats in the intestine. And so if you have an accumulation of these bile salts, and some of the food that's fatty slips around this accumulation, then you can actually have kind of a fatty diarrhea. And that can lead to debilitating episodes of diarrhea. And again, I've seen patients that wouldn't tell us that they had diarrhea because they didn't think we had any solutions for it. Now we know it's a bile salt malabsorption syndrome. And so if it occurs, we usually have patients hold their Revlimid for a bit, especially with their maintenance, have the diarrhea resolve. They can try to use Imodium if it's more of a mild bile salt malabsorption syndrome, and try low-fat diet to decrease the fat that is escaping the bile salt malabsorption syndrome, which then can decrease the diarrhea. But one of the mainstays is using bile salt acid binders to get rid of those pools of bile salt. And cholestyramine, which I do prescribe to my patients that have diarrhea. And it really does work quite dramatically. And it really is a test. There are lots of causes of diarrhea, but if you use cholestyramine or go on a low-fat diet, your diarrhea resolves, then it's that bile salt malabsorption syndrome that is seen with Revlimid. And I would encourage you, if you have diarrhea, to definitely discuss that with your doctor so you don't have to live with that. Another thing that we found out with the use of Revlimid, especially when we use it in combination with other drugs, is the risk of blood clots. There are a number of different risk factors of blood clots. And every time I see a new patient with myeloma, I go through this checklist in my head to see, well, what are we going to do about blood clot prevention in this patient? And especially if patients are newly diagnosed and myeloma is reactive, or any cancer is a risk for blood clots, but active myeloma is definitely a risk factor. The use of chemotherapy in association with Revlimid increased the risk of clots. And high-dose dexamethasone, like 40 milligrams of dexamethasone days 1 through 4, 9 through 12, and 17 through 20, which isn't used very much these days, also with Revlimid increased the risk of blood clots. If you're using erythropoietin, the blood cell stimulating agent, it can increase risk of blood clots. I always ask, and you should definitely volunteer if you've had a blood clot, a history of having a blood clot, to definitely, that is one of the big things that we need to know that would cause someone to have a high risk of having blood clots with Revlimid, or a family history, thrombophilia, having genetic conditions which predispose people to blood clots, and of course having surgery or broken bones can increase the risk of having blood clots. Not many patients with myeloma have central venous catheters these days because we don't use chemotherapy, but also having something abnormal in your blood vessels, like an instrument, can increase risk of blood clots. So if a patient doesn't have a lot of those risk factors, we just use a daily aspirin. And I usually use an 81 milligram aspirin a day to prevent blood clots. However, if patients have one or more of those risk factors, and I would say older age is primarily getting at someone who's very sedentary, who can't move around a lot and has active myeloma. But if they have two of these risk factors, then we would give consideration of using one of the oral blood thinners like Eliquis or Xarelto, not much warfarin anymore, or subcutaneous blood thinners such as Lopinides. We're very cognizant of people having blood clots in the first 6 months, so we definitely watch people we watch people all the time, but we watch them in those first 6 months carefully. And the signs and symptoms of blood clots is having one leg swell larger than the other, redness in that leg, or pain in that leg. It is usually in the lower extremities where they occur. And what's interesting is I think a lot of the commercials that you see will talk about blood clots and people having pain. Interestingly enough, when patients are on Revlimid and they have a blood clot, it doesn't always have pain. It'll primarily be that swelling in one leg that really should have you immediately seek the advice of your physician. And we tell patients the best they can when they're diagnosed in the first 6 months to really be as mobile as possible. That moving around circulates the blood, keeps it from pooling in the lower extremities, which can cause the blood clots. Some of the other side effects that we see with Revlimid, fatigue. And it's important to really, and when my patients say they have fatigue, the second question I ask is, how is their sleep? Because as you know, the dexamethasone can really cause havoc with the sleep. To make sure the hydration is adequate and they have good exercise. Sometimes when patients are on Revlimid maintenance, they will do a dose reduction, or we'll have them take a holiday. And when my patients go on vacation and they're on maintenance Revlimid, they usually take a vacation from the Revlimid too. I says, leave your Revlimid at home. Being off Revlimid for a week in the order of maintenance therapy isn't going to have any effect to the myeloma. For the leg cramps that can accompany a Revlimid, that L-glutamine, the supplement, can help. Definitely hydration and normalizing the magnesium potassium levels. One way to do that, and I have a couple of patients who swear by this, is pickle juice, which has a lot of magnesium, phosphorus, and potassium in it. They drink pickle juice right before they go to bed, which helps as a muscle relaxant, and it helps decrease the cramps. But moving and stretching and being active helps a lot with the cramps. And then the rash, the Revlimid rash. And I think I had mentioned earlier that when Revlimid inhibits Ikaros and Alos, and it causes changes in those cytokines that help destroy the myeloma a lot and activate those T cells. That when you first start Revlimid, it can cause a rash with activation of those T cells and activation of those cytokines. So it's not uncommon, about 10% of the time, patients will start Revlimid and have a rash. We tell patients to hold the Revlimid, give us a call, hold Revlimid, and call us when the rash is resolved. And we'll recommend antihistamines, topical steroids, and sometimes if the rash is severe or is worse, then you have them take oral steroids to help with the rash. Rashes can occur later on with Revlimid, especially after transplant. Some of those are rashes due to dry skin, because Revlimid can also cause dry skin. So definitely wintertime, we tell people to use moisturizing lotion. So what's new with Revlimid? Well, there is in development, there is a transdermal patch for Revlimid that is in development, and I think is in kind of the later phases of development, where instead of having the Revlimid, when you take a Revlimid pill, the drug effect peaks, particularly when patients take it at night, and then decreases. While a transdermal patch of Revlimid would have a more continuous administration of the drug over a longer period of time. And I think what a lot of us have been, what I have been praying for a long time, for about a decade, is generic Revlimid, and that there are actually two companies that have FDA approval for generic Revlimid occurring in May and October of 2021. The generic Revlimid, especially by Teva, is being rolled out in a volume restricted basis, which means that available at some places, but not available at all places, and is slowly being increased in its release over time. And the availability of generic lenalidomide varies from state to state. And we are calling right now to see if it's available in Michigan yet. But the one trick is we don't know what the cost is going to be. We suspect it's going to be lower for sure, but we don't exactly know the cost because the company sells it to a wholesaler, which sells it to a drug company that sells it, to the pharmacy, that the pharmacy would probably be, the individual pharmacies would probably be the best idea of how much a drug would cost. And it would still require the REMS program. And just one word about the REMS program. The REMS program was actually developed, again, for thalidomide. And it was developed with the help of the thalidomide, the people that were affected, the children that then grew up with the teratogenic effects of thalidomide, helped develop the REMS program so that it would be rolled out in a safe manner. And so every time that patients use the REMS program, that was actually developed to keep it safe so we wouldn't have more thalidomide occurrences, thank goodness. So in conclusion, there have been dramatic improvements in the treatments for myeloma with the application of immunomodulatory drugs, especially Revlimid. And again, I am so thankful for that patient's wife and that patient, and Dr. Barloghi and Judith Folkman for bringing this to fruition. It is now the standard induction therapy and maintenance therapy, and most patients that have myeloma will be on Revlimid. It has side effects that we talked about, so it's important to be frank and open with your nurse and doctor to really give the best advice. And I would also say it's important to be open with and frank with the care coordinators and the social workers to help, because these drugs are very expensive, and to help with the cost of those drugs. But it's critical. I always end every talk that I do with how important it is to be informed and empowered. And I thank you so much for listening to me talk about these drugs today, because it's important to be empowered in 2022. So many exciting things are happening in myeloma that it's important to be able to talk to your doctors about all the new things that are happening, because you can cope with this disease better by empowering yourself with knowledge, to learn what you need to gain control, and to surround yourself with positive people that can help you fight this disease. And that's it. Thank you. And
Awesome. Thank you, Dr. Cole. That was truly an excellent presentation. You always come with some great animations with really help with understanding there. So thank you so much. It's time for our Q&A now, and we have quite a few questions that's already in the chat box there. So we're going to jump directly into those. If you do have a question, just feel free to put it in the chat box there, and my team is going to funnel those into me so we can get them answered there. But we're going to go ahead and get started. Dr. Cole, the first question that we had is, what are your thoughts on receiving medications to stimulate the red and white blood cell production versus using the RVD treatment?
yeah, I think that that using, and I think, so I'm trying to think what this question is asking. So I think that when Can you use those drugs while you're receiving RVD treatment? Yes. It's not infrequent that patients that have myeloma have anemia, which the red blood cell producers help with, and neutropenia, which helps the white cells with, especially when you combine the disease with the medications. And so I think it's important, especially to reduce risk and have patients feel better, to use those stimulators to help stimulate the blood cell production. Using it instead of Revlimid, if you're anemic and you have a white blood count from myeloma, stimulating the cell production to correct the anemia instead of using definitive therapy is like putting a Band-Aid over. It's like putting a Band-Aid over a wound. A wound that you need stitches for. So it won't help that much. Just to stimulate the white and red blood cells, you need to get rid of the cancer that's causing those counts to be low.
Thank you. It's a very good question. The next question, would the use of Revlimid increase ONJ, the oxidative curses of the jaw activity?
That's a very good question. They're all good questions, but so it has a little bit of that, very small degree, definitely compared to the bone strengtheners like Zometa and Xgeva, which definitely has more effect on the bone and does increase the risk of ONJ much higher. The Revlimid is kind of small potatoes in increasing the ONJ risk. And so definitely when patients are getting teeth work done, they're getting a tooth pulled, and they're on Xgeva or Zometa or Pamidronate, I definitely hold those drugs. If patients are getting teeth work done and they're on Revlimid maintenance, what I'll usually do is I'll ask them to hold the Revlimid for about a week. The week before they have their dental procedure done, in part because there is decreased healing associated with the use of Revlimid. That with any surgery, that it'll just take longer to heal from things. And so I'll usually hold the Revlimid briefly, so usually about a week before or maybe a week after they're having major dental work done, just to make sure that things heal very well.
Thank you. So the next question, can you explain the VGPR, the very good partial response, and other related responses there? What does that mean?
Sure. If I can share my screen again, if that's okay. And let me share. Come on. And so there we go. Do you see my screen? Okay. Perfect. So on the right, there's the myeloma iceberg model. And when patients are first diagnosed with myeloma, usually it's pretty obvious that they're having anemia, bone lesions, and their myeloma burden is very high. And as we treat the myeloma, then as you get rid of it, then the myeloma begins to go beneath the waves. And so, when you have, and we measure how much myeloma there is by the M protein or by the light chain protein. And if your light chains go from 100 to 50, that's a 50% reduction in the protein level. If your M protein goes from 5 to 2.5, that's a 50% reduction, and that's a partial response, which is very good. But a true, very good partial response means that you have a 90% reduction, where the M protein from the day that you start therapy to the point that you are right now, if 90% of the protein has been decreased, then we call that a very good partial response. If the M protein disappears and the immunofixation, the most sensitive test to tell if there's an M protein, disappears, then that's a complete remission. And a stringent complete remission is when you do a bone marrow biopsy and you don't see any plasma cells, and the free light chain ratio is between the abnormal and normal light chains has normalized. And even below that, there are lots of clinical trials, and really it's becoming part of standard practice to measure MRD, because the tests that we use to measure myeloma burden, so I talked about the M protein using the SPEP, that dates back to the 50s. That's an old test. And the light chain test dates back to, I think, about 2012. So they're older tests. And even if those tests are negative, there's still some residual myeloma there. And the minimum residual disease testing, either by flow cytometry or next generation sequencing, can give us an idea of deeper responses, looking for 1 in a million or 1 in 100,000 myeloma cells.
Okay. Thank you for that explanation.
Sure.
And Shirley has in the chat, this is such good information. I agree. It is awesome information that we are receiving here today from Dr. Cole.
Oh, thank you.
So Dr. Cole, the next question is, you mentioned the side effect of diarrhea, but what about severe constipation and stomach pain? This patient, I had an endoscopy and a colonoscopy and the doctors found nothing. A CAT scan was also performed and found nothing. I have tried several medications to help, but nothing seems to work. Do you have any suggestions for this patient?
Yeah, I have seen that occur where patients, instead of having the diarrhea, especially early on in their myeloma course, that they can have a pretty bad constipation. And a couple things is one thing that I'll mention a million times over is increasing the fluid intake. That there can be mobility issues where the colon and the bowel and the intestine should push things along in an orderly manner. That you squeeze here and it pushes things, and squeeze here and it pushes it. And sometimes that doesn't work very well. And so increasing the fluid intake kind of helps keep fluid in the bowels, which can help things move along better. But also things like increasing the amount of fiber in the diet and fruits, especially things like prunes, can help a lot, because that helps keep the fluid. Those are foods that help keep fluid in the intestine that's not absorbed by the body. And that increased fluid mixed in with everything else can help keep things running well. I think one other important thing is to make sure your thyroid's doing okay, because one thing I didn't put as one of the side effects that definitely happens when people are on Revlimid is they can have low thyroid function. And so it's, and I've seen a number of times where patients have been on Revlimid for a while. And I remember in the first clinical trials that we had with Revlimid, the patients would have constipation and they would have a hoarse voice. And we would check the thyroid, and the thyroid function was very low. And it's easily correctable with a thyroid replacement therapy, just a thyroid pill. So in addition to everything else, I would definitely increase the fluids, increase the bulk, using things like fiber in the diet, but also make sure you check your thyroid function.
And a follow up on that, Dr. Cole, if there is an issue with the thyroid function, would that be ongoing as long as you're taking the Revlimid, or it is?
Yeah. And so I haven't found it to be prohibitive for it. And people don't require lots of thyroid medications to correct the thyroid with Revlimid. So even in the first clinical trials, we didn't stop the Revlimid because it caused thyroid dysfunction. We just replaced the thyroid and on people went.
Awesome, thank you. Is it more effective to take Revlimid at a certain time of day, say the morning versus at bedtime?
So I laugh because because I'm just going to keep saying in the early days and back in the old days, back in the old days, because thalidomide was so sedative and really, it was a really good sleep agent. We were treating patients initially with myeloma. We always had patients take it at night because it helped patients sleep. And when Revlimid came out, even though they made sure it didn't have a lot of the sedative effects, we still had patients take it at night. And I still think that's not a bad idea to take it at night. So if there are any side effects, that people just kind of sleep through it. I think it's more important to take it at the same time every day. I have had patients have a bit of insomnia with the Revlimid. So they take it at night and say, I really am having poor sleep. And then I'll say, well, try and change it to the middle part of the day or the morning. But because really it taking at night is more of a historical significance, more in its relationship to thalidomide than it is actually something that is therapeutic.
Thank you. So this is a good question there. If pomalidomide is more powerful, why is it not used more than the lenalidomide?
Oh, that is a very, they're all good questions, but that's a very good question. That I've asked that question to the company, that may change. The standard, at least what I was told, is that Revlimid has really shown its proof in that upfront therapy for myeloma, and pomalidomide has such good effects in the relapse setting, especially in some of the trials using pomalidomide, of how it was active, especially in patients that have the 17p deletion or have high risk relapse myeloma, that it was like, leaving your bigger punch for your last punch or for the next punch, that you use a standard therapy for upfront. And then when the myeloma comes back, and especially if it's a high risk relapse, that the pomalidomide is there to save the day. Given that there are a number of different drugs, the two things that really changed that paradigm is one, that there are other now very, I had mentioned how it is blind luck that pomalidomide and Revlimid and thalidomide fit into that cereblon keyhole. Now there are pure cereblon and Ikaros and Alos inhibitors that are much more potent than Revlimid, pomalidomide, and thalidomide. And when those drugs are currently in clinical trials, such as iberdomide, and when you look at those drugs coming in and the generic use of Revlimid, the pomalidomide is going to be under a bit of a squeeze. And it'll be interesting to see if leaving that drug for rainy day, if we're not going to move that up a bit more upfront, as we're having newer drugs come down the pipeline that occupy that same space. That's a very good question. I have asked that question repeatedly.
Thank you. And we'll make this the last question here. There's plenty of questions in the chat there. We have your email. We will get responses to you to these questions. But we have to make this the last question here. For Revlimid maintenance post-stem cell transplant, do you prescribe 28 days or a 21 day with the 7-day off regimen? Which do you prefer?
So I'll be honest. So when we were, there are two schools of thought. And I can tell you, I've attached my school to the 21 days on, 1 week off. And for the long term. So soon after transplant, when I started, I usually will start with the 21 days on, 1 week off, especially because after transplant, when we start, that the counts may be a bit rocky, and it's a bit more palatable doing the 21 days on 1 week off. Once they kind of get into the groove of it, and once it counts and they've like really recovered from the transplant, like 6 months or a year after transplant, then I'll move to the 21. Then I'll move to the 28 day. There isn't really a solid answer for that. They're both very efficacious. I think if you survey most of my patients, we have negotiated to the 21 day on 1 week off. I think it's actually kind of helpful to see when patients have that 1 week off, especially if a patient tells me, oh my goodness, that 1 week off is the best week off ever. Then I'm like, okay, we need to have that week off. If they have that 1 week off and they say, really, I feel fine, I can't tell the difference, then maybe I'll move them to the 21 to the 28 day. But there really isn't a solid answer. And I think the bulk of my patients are on the 1 week off kind of regimen. As I think it's just easier and it gives them a week off. And one thing that I tell patients, one thing that I would encourage you to talk to your doctors about is I'm 6'5", and so when I get on an airplane, it's a kind of a pain. But I'm willing, when I get on a little small puddle jumper, I'm willing to put up with having my knees at my chin, because I know it's a short ride. And that's like induction therapy, that you put up with a lot of pain, put up a lot of hassle, side effects of the drug, but it's a short flight. That, if you're going to transplant, you're only going to be in about 4 or 5 months. Or if you're not going to transplant, you'll be in 12 months. Then you'll be on maintenance. And so you're willing to put up with, just like I'm willing to put up a lot of pain on a short flight. I'm willing to put up with some pain. If I'm flying to California from Michigan, or flying from Hawaii, I need to be comfortable flying. And maintenance therapy is like that long flight. You have to make the seat comfortable. That I make sure I pay a little bit more money for, not first class, I can't afford first class. I haven't even been in first class before. But I'll get the larger seats and everything. Make sure I'm comfortable because it's a longer flight. So when I talk to patients about maintenance therapy, it's like that long flight. What can we do to make this the most comfortable ride? Because it's the long haul. So I have patients on 10 milligrams, I have patients on 5 milligrams, I have patients on 3 weeks on, 1 week off, I have patients on 5 milligrams every day. But I find what is the most comfortable for that long haul, because thank goodness in 2020, that after that transplant and that maintenance therapy, that is a long ride till the myeloma comes back. And you need to make it comfortable so you can enjoy your life.
Thank you. Thank you, Dr. Cole. Thank you for being here with us today. We
Sure.
always enjoy having you.
But thanks for listening to my, it still is, moving to see where things have come. And I do, I know that most of the people here were doing other things back in 1999 and in 1998 and in 1991. But gosh, it really is incredible what's happened. And I would never had dreamed that things would be like they are now, and things are going to be so much better. It really is incredible. So thanks for listening to me kind of reminisce about the old days.
Thank you. It's a good time to have myeloma. I really believe that with everything that's going on there. So thank you for being here with us today. You may be interested in other myeloma crowd community events that we do have coming up. On Saturday, April 30th, we have the Chicago Myeloma Roundtable, be held in Schaumburg, Illinois. The morning session is going to focus on introductory myeloma with Dr. Maury Gerbs. He always gives a great speech on the weeds in the garden. If you haven't heard that yet, you want to tune in for that. And he's also going to be talking about other important issues to patients that have the precursor conditions, newly diagnosed patients, or patients that are in their initial treatment phase. It's going to be a good experience, a good meeting for refresher, experienced patients. Wherever you're at along the journey, it's going to be a good meeting for you. The afternoon sessions topics are going to be centered around treatment issues for patients with relapsed refractory disease and how new therapies are being integrated into patient care. There's going to be a great panel of myeloma specialists there. So there's still time to register for that, either the in-person event or the live webcast there. Now join us next month on May 27th at 2 o'clock. We're going to hear from Will Wright. He's an African-American man who made an incredible transformation in his diet and in his life. He made this his mission to educate other African-Americans on how they can improve their diet and still keep their culture. So Will is going to break down many of the myths associated with a plant-based diet and how we can prepare our meals in a non-traditional manner, but still maintain that flavor and goodness that we're accustomed to. I always say healthy eating doesn't mean giving up our rich culture there. Also, Tuesday, May 3rd at 1 Eastern, the Myeloma Financial Chapter is going to talk about how to pay your expensive medical bills without going bankrupt. Wednesday, May 4th at 7 p.m. Mountain Time, the HealthTree Moves for Myeloma chapter is going to be discussing how Pilates can benefit myeloma patients. The link to sign up for any of these events and even more that I haven't mentioned today is found at the bottom of the slide and will be sent out in a follow-up email within 48 hours of the event's completion. So as always, I want to thank our sponsors without whom this would not have been possible. Bristol Myers Squibb, GSK, Genentech, Janssen Oncology, and AbbVie. And thank you all for being here to help us build a strong myeloma crowd community. I appreciate each of you and hope you enjoy the rest of your day. Bye-bye.